Dentists often execute technically flawless full mouth rehabilitations and composite bonding, only to watch those materials chip, fracture, and fail prematurely. Material science dictates these restorations should last for decades. When they break down predictably fast, the problem isn't the material. This animation shows what happens during sleep when a patient's airway collapses. The body initiates a mechanical survival mechanism. The mandible aggressively postures forward to open the breathing passage, and in the process grinds the anterior teeth against each other. This action converts a respiratory crisis into a physical one. Sleep-disordered breathing generates immense occlusal forces that no composite resin or ceramic can withstand over time. Stopping this cycle requires moving away from isolated structural repairs and adopting an airway sympathetic approach, where the biological environment dictates the dental treatment. Implementing this requires a precise 4-step clinical workflow: visual screening, interpreting diagnostic data, patient communication, and targeted therapeutic intervention. Until the patient's airway foundation is identified and secured, long-term restorative predictability is structurally impossible. Comprehensive airway screening does not start with a sleep study. It begins with physical, visual assessments during standard intraoral examinations. The initial indicators are purely anatomical: a scalloped tongue edge, a high vaulted palate, or restricted intermolar widths all signal a compromised space for the tongue to rest naturally. The Mullen-Potty score is a direct risk multiplier for sleep-disordered breathing. A grade 1 reveals the entire uvula and tonsillar pillars, while a grade 4 shows the tongue obscuring the airway entirely. The clinical weight is mathematical. For every single grade increase, airway risk doubles. Beyond soft tissue, the teeth themselves hold a physical record of airway struggle. But we must differentiate between wear caused by skeletal disharmony and wear caused by airway compensation. Skeletal wear usually indicates a constricted envelope of function. This occurs when there is a strict mismatch between where the teeth fit together and where the condyle sits neutrally, causing friction upon closure. Airway-driven wear looks completely different. When a patient gasps for air during sleep, the jaw is thrust from the inside to the out. This creates highly specific anterior wear patterns that do not align with standard functional movements. Severe anterior attrition is an active historical record of the body attempting to force oxygen into the lungs. Once physical red flags are identified, the suspected risk must be quantified through objective data. This requires comprehensive multi-night sleep testing. The standard metric provided by most sleep tests is the Apnea-Hypopnea Index, or AHI. However, this metric has strict diagnostic limitations that can obscure severe pathology. On the left is obstructive sleep apnea. A severe event requires a 10-second cessation of breathing, synchronized with sharp blood oxygen drops. But AHI has a blind spot. A patient could stop breathing for 9 seconds repeatedly, scoring 0, and appear completely healthy. This specific diagnostic gap is known as upper airway resistance syndrome, or UARS. With UARS, airway narrowing triggers a fight or flight response, forcing a microarousal to keep the airway open before oxygen drops. On the UARS hypnogram, oxygen remains stable, but sleep is highly fragmented. The patient is repeatedly pulled from deep sleep into brief wakefulness. Catching these specific fragmentation patterns requires monitoring the central nervous system over several sleep cycles, making multi-night testing mandatory. Relying solely on oxygen knee saturation will miss the patients whose nervous systems are silently destroying their dentition. Securing objective data is only the first half of the process. The clinical rule of airway management is that you cannot convince a patient they need treatment. You must guide them to own their data. This begins prior to the consultation by utilizing targeted intake questionnaires, shifting the diagnostic burden to the patient's own self-reflection. During the exam, frame the conversation entirely around their answers. By stating, "You've told me you experience chronic fatigue and fragmented sleep," you present their symptoms as objective data points rather than clinical accusations. Once the airway risk is acknowledged, you connect it directly to the physical state of their teeth using material science metrics. A biologically normal chewing system loses roughly 11 to 15 microns of enamel per year. When you present an intraoral scan showing 1.4 millimeters of volume loss to a 30-year-old patient, calculate the math for them. That measurement equals over a century of wear. Their teeth belong to a 130-year-old. Transforming abstract clinical measurements into specific, highly personalized evidence strips away patient resistance and establishes immediate urgency. With the diagnosis accepted, the patient's biological environment must be stabilized. The clinical imperative is to systematically lower the airway risk before initiating any irreversible dentistry. The first tier of intervention evaluates nasal resistance, looking for the most conservative solutions possible. A highly effective diagnostic step is to have the patient test inexpensive magnetic nasal dilators at home. If flaring the nostrils dramatically improves sleep quality, the upper airway restriction is successfully isolated. The next tier is myofunctional therapy. For adults, this means actively retraining tongue posture to rest against the palate and establishing a consistent lip seal. Myofunctional therapy improves soft tissue anatomical tone. This direct conditioning increases patient adherence to advanced therapies like CPAP machines and reduces the amount of forward titration required for an oral appliance. To determine if an appliance is appropriate, clinicians can deploy a crude but effective physical test. Have a patient who snores recreate the sound, then ask them to manually protrude their jaw. If bringing the mandible forward makes it physically difficult or impossible to produce the snoring sound, it clearly indicates that a mandibular advancement device will effectively open the airway. Systematically deploying these targeted, non-invasive therapies ensures the restorative dentist is not attempting to build an occlusion on a collapsing physiological foundation. Once the airway is stabilized, the focus shifts back to the restorative chair, where the dentist must manage the mechanical reality of a patient relying on a nighttime appliance. The primary clinical side effect of mandibular advancement devices is an unwanted shift in the occlusion over time. After being rigidly held forward for 8 hours, the condyle must squeeze back through the viscous synovial fluid of the joint. Without guidance, the mandible often fails to seat back into its original skeletal home. To protect the dental rehabilitation, the clinician must execute a strict morning reprogramming protocol to correct this instability. This diagram shows a morning occlusal guide in action. It is a thin, flat Essex retainer recorded in full interdigitation prior to the delivery of the advancement device. When worn, it physically guides the displaced condyle back into its neutral, stable position. Wearing this guide for just a few minutes every morning prevents permanent bite shifts and preserves the carefully engineered occlusion. The airway dictates the starting diagnosis, and it is the final variable managed to ensure restorative success. It serves as the absolute bookend of dentistry. By integrating airway health strictly into treatment planning, clinicians accomplish two things simultaneously: the biological environment thrives, and complex restorations survive.